Mm.
Morning, everyone. We're just going to let people filter in here. Happy Friday. Thanks for being with us.
Mm-hmm.
Okay, well, we can get started. More people can trickle in as time goes on. But yeah, we can definitely get started.
Okay. Oh, hello, everybody. Nice to see each other again. Sort of see each other. So today we'll do kind of a recurring theme around caregiving because it's a biggie. It's a perennial issue. It's an ever issue. So there's always stuff to talk about. Reminder, if you've been to these before, there's going to be some redundancy with the slides. We're just going to sort of level set, and then we'll open it up for a conversation. If you've been to this before, you'll notice some of the same themes in this caregiver series. A lot of the action is in the discussion. And yes, guys, today we have two people. You've seen them before. We've got Bridget Sumser, greatest social worker in the world, and we've got Dani Chammas, greatest psychiatrist, palliative care doc in the world. And we all know each other from UCSF, but beyond too. And so I'm really, really happy to have you guys here. Thank you, thank you, thank you. And then a reminder for anyone, reminder for old guys, for new guys, this is meant to be very informal. Really, you can ask anything, you can say anything within the bounds of basic morality and kindness. So really a safe place. You can speak up or you can not speak up at all. That's Maisie in the background. I don't know if you guys can hear her groaning for some reason. Anyway, so with that, over to you, Sonia.
Thank you, BJ. Hey, everyone. Thanks for being with us today. And also thank you, Dani and Bridget. So excited to have you here to talk about this stuff. So after BJ, Dani, and Bridget get through the slides, we'll open it up to questions from you. And you can ask these in two ways. You can raise your hands and we'll unmute you and you can ask your question out loud and discuss it with our three lovely hosts, or you can type it into the Q&A and I will read it aloud for them to answer. So two options: raise hand, ask your question out loud, or you can type it in. And to BJ's point about a safe space, if you would like to remain anonymous, that's no problem. Please just let me know in the Q&A when you write your question and I will be sure to not mention your name. Thanks everyone for being here. Really appreciate it.
Thank you, Sonia. And as ever, credit for Sonia for all the artwork. Dani, there may be some of your artwork in here too this time. I can't remember.
I don't think so.
Okay, well.
Oh, we should have done that. That would have been great. Sorry, Dani.
But big thanks to Sonia for the visuals here. She pulls are so perfect. Only we could be more perfect if Dani's were in here too, but next time. Okay. All right, here we go, guys.
All right.
Dani, I know you got something to say on this.
Well, no, I think we just, it's before we sort of got going on this topic, we did want to take a moment and just acknowledge the fact that we're all, unique individuals and unique circumstances. And so no two caregiving relationships or journeys is going to be the same, right? So some of the stuff we say is going to totally resonate with you and some of it won't. And that's okay. Right? If you think of sort of the sheer volume of feelings or experiences a caregiver can have, it's huge, right? Things from, compassion and joy and a meaning and purpose to things, like exhaustion, isolation, grief, overwhelm, guilt, powerless, you name it. And not all of us are going to be tapped into all of them at the same times. So as we talk, I think we just have to hold the fact that our experiences are complex and they're part of a bigger whole. And when we speak to one part of our truth, it doesn't mean that we're invalidating another piece of it, right? Caregiving can be intensely rewarding and can be this tremendous weight or burden. And talking about one or two sides of that coin doesn't mean we're denying the other side.
I think it makes me think, something we've talked about before too, is just that like not every caregiving relationship feels plentiful in love, right? Like there's all different ways in which we relate to one another and have responsibility to and for and with one another. And, we want to make sure that we're making space too for relationships, caregiving relationships that are complicated.
Yeah.
And I know sometimes I will tend to talk about caregiving as this vaunted, loving place, and a lot of my comments will presuppose that there's affection between everybody involved. And as you guys are pointing, that's not always true. Sometimes we just stuck with this job, or we have many feelings, as Dani was saying, about this job or this person, etc. So it's complicated. And please don't let us alienate you if we talk too much about love and sweetness in the background, because we just know that isn't always the case. And I think one of the things that this kind of work does is it gets you in touch with reality and honesty, hard truths. So we'll try not to make the mistakes of accidentally alienating any parts of that truth. And one more thing to say about this is a lot of people won't, the word caregiver just doesn't register. That's my mom. I'm not her caregiver, I'm her son, or, whatever it is. So also if the language doesn't resonate with you, family, friend, caregiver, whatever it is, we're talking about much the same stew. The words just may not light up for you one way or another.
And we would love to know your words, actually.
Yeah.
I feel like this is something, in professional spaces that we're always talking about, like, oh, let's not say loved ones. Let's not say family. What should we say? And so if there are words that describe the relationship to you and feel authentic and you feel like sharing, and we don't cover them, we'd love to hear them.
I kind of want to make that part of my intake interview with patients and caregivers, like asking the
That's a great
yeah, how would you identify yourself or something? I like it. Anyhow,
we're learning.
We're all learning.
Beautiful. Okay, guys, shall I move us ahead here? Yeah.
All right, marathon versus sprint. I love this one because I think, for better or for worse, this caregiving role, it just never really turns off, right? It's constantly on. And so when we think about a marathon, which I think is such a beautiful analogy, I think the key or core issue here is sustainability, right? What are the ingredients of sustainability? Or, said differently, how do we cope with what's being asked of us and the feelings that come up in a way that allows us to get up every single morning and continue doing it? I would venture to say that all three of us could probably do a 10-week course on this topic and not hit it all, but there were a few concrete things that I did want to mention that I think do help us stay a little bit in this marathon mindset. The first, I think, is checking in with ourselves, right? Taking a moment every morning to ground ourselves and take a deep breath, focus inward, and just ask, where am I at? How am I doing? Right? Where's my reserve at? Ask me later, and I can tell you all about my 6-year-old's chicken check-in. But that's probably a story for a different time. But checking in, and I would say hand in hand with checking in, is just accepting non-judgmentally whatever our feelings or experiences are, right? Easier said than done. I think we talked about that one at the last talk. So we know where we're at, we accept where we're at. And then I would say the last ingredient is letting that inform the choices we make, right? Maybe my reserve is super, super low on a day and something has to give. And I have to find something to say no to. Right? No, it's like one of my favorite words these days. It's so powerful, right? So what do I have to do? What could I say no to, right? BJ, do you want to invite me to be on the financial talk that's coming up?
Yeah.
No, because I don't have the capacity for that right now.
It's like, where are you going with this?
No, but you guys know, there's a chaplain on our service, Judy Long, and she talks to us a lot about setting intentions, right? Taking time every day to ground ourselves and set an intention, even if it's tiny, but attainable, right? I'm going to find a few minutes to go outside today. I'm going to reach out to a friend today, even if it's just a text, I'm going to be mindful of saying kind things to myself today. The idea being that there's value in going through sort of the act of consciously intention setting. I could talk about marathon versus sprint forever. So I'm going to pass it off to you guys to see what comes up. But
Well, one thing I was going to jump in there is, it's also worth noting what the situation is, your own reserves for sure, but also what's the situation. So if someone's in the ER and there's, fires going off, you're in acute kind of crisis mode, well, that's one thing. You put a lot just has to go on hold, but you really need to look for when you need to get out of that crisis mode as soon as feasible. You can't live in crisis mode. That's not a sustainable energy. You just can't. So it also, part of taking stock is what's called for this day too. And sometimes in acute mode, it is really putting life on hold. It is kind of holding your breath to kind of get through it. But very often you're not just trying to get through it. The needs are inexhaustible. And if you're waiting for it to be done until you relax or something like that, well, don't, because it won't be done. Back to the charm of Judy's point about just, there's a mountain of things to do. So pick one or two and just do those today. See if you can get outside for a couple, whatever it is. I think doable. Bridge, anything to add to that?
Yeah, I mean, full disclosure, I have not ever run a marathon. I will not ever run a marathon. So this is like some.
I'm so with you.
But so I hear, you feel all the feelings, right? You get into strides, you hate it, and your body hurts. You feel like, oh, this song is good, and I'm okay. Oh, I'm getting close to the end. I have anticipation about that. Oh, I'm just starting. I don't know what this is going to look like, right? Like all of the feelings come in and go and are maybe overlapped and are welcomed and are normal and are common. I think that we sometimes can get like tied up in some knots, especially when we're like, oh, but I do love this person. I do love this role, but it's hard today and I don't want to do it. And that's just a common feeling.
I'm not even going to tell them what you said about your kid right before we started.
Oh, well, I've already forgotten. So good. You're welcome to.
No, but we were just joking about the same thing, right? Like, gosh, yesterday it was so great. I was just loving all my kids and it was wonderful. And this morning I just want to scream a little bit, right? All the feelings.
Yeah, and that real like things can go from feeling like manageable to that, and then they can switch back. And part of the taking a moment just to find a breath or an intention or some sense that you can access is that like it does change, and it can change quickly, and we often don't anticipate that in any direction, really. The other thing I'll say is like with the marathon thing is like there is a clear end to a marathon, and there isn't always a clear end, and or the end is a death. And so that's a hard thing to feel like, oh, I'm going to cross the finish line. And then there's something celebratory there, right? And so just to hold the like ambiguity around when the caregiving role ends, and that it's accompanied with, or shifts, it's accompanied with grief and loss. And
yeah, it's running a marathon in the fog, right? You can't see when the finish line's coming, and it might actually be a really crappy finish line. So
Well, we have really beat this analogy.
None of us run marathons.
Wow. Okay. Speaking of marathon versus sprint, should we get off this slide finally? Just kidding. Okay, you guys, hang on here. Fun ADLs. Well, jokes aside, I mean, ADL's activities of daily living, in the phrase is kind of boring. It just, I don't know. It's just, this is medicalese. So this is a phrase. It is kind of just maybe descriptive. What happens in a basic living? ADLs is sort of basic stuff to get through the day. But it also, that phrase, just to note, you may hear that it also has meaning within sort of the health insurance world, and you qualify for different services depending how independent or dependent you are for any of these particular needs. So there's, just to note, not to weigh us down with that sort of official background health insurance-y stuff, but just know that these are of some significance in multiple ways. So these are the basics: bathing. These are self-explanatory. Bathing, dressing, eating, transferring, and transferring maybe not self-explanatory. It's sort of moving, say, from a lying position to a sitting position, perhaps getting from the bed to a chair, from the bed to a commode, from the bed up to a wheelchair, whatever it is, moving from one zone to another. And that's really, really key for everybody involved. You need to keep moving one way or another for the sake of your skin's health, et cetera, for your circulation, et cetera. And then on the caregiver side, the transferring is often where injuries happen. So it's really important to learn how to help transfer someone well. Oftentimes, if you're in the hospital setting, you're about to go home, this may be something that a physical therapist or a nurse can help train you a little bit around. And if they don't offer it, you should probably ask. Again, this is where back injuries are very common. And caregiving is a dangerous sport. We know this. It's taxing physically too. And this is one of the places where it is. Toileting, basic continence issues, helping people get to the bathroom one way and another. Continence, well, sorry, I just conflated those two. Continence is really, it's a big one. I'm on the patient side. I know many people who have kind of put up with incredible medical loads and watched one part of their body fall apart after another. Not infrequently, it's the continence, urinary or fecal, losing your bowel or bladder function, that can, for so many people, just be the last straw. They can put up with so much, but this one is really, really tough. And so with all of these, you note, yeah, they're sort of physical, physiologic, but they have a lot of emotional content to them as well. And this word dignity that comes up for people. I mean, a lot of us would define dignity for ourselves. I mean, what I think of as dignity may be different for you. And there's all that kind of subjectivity over all of this stuff, personal preferences, et cetera. But just to say, these activities are not just sort of motions. The style, the love, the affection, whatever you bring into this mix also matters a lot. How you do this matters a lot. A lot of us, anyway, I'm going on too much, but I'll just say that dignity is wrapped in here too. Okay, take it away, ladies.
No, I agree. And I think, when I hear you talking, it's making me think about how one of the really unique challenges I think about caregiving is that it's so much work, but it can be really hard to complain, because just like you're saying, like the person that you love is sick, right? The person that you love is potentially struggling with these threats to their dignity, right? These deep fears of being a burden. And I think it often puts caregivers in this really unique position of having this incredibly challenging role, but often not feeling worthy of having attention or compassion spotlighted on it because of that dynamic.
Mm-hmm. Yeah. And this is one sometimes too, where it can be really hard if you're, bathing, for example. The first time a child maybe sees their parent nude, it can be very vulnerable making, can be very difficult. And it's also okay if you, oftentimes, just like we said, this is a team sport. So there may be other caregivers, paid and otherwise, around to help. And so some of these things you may opt out of, especially if there's someone else to do it. One way or another, these things need to get done, but they don't always have to be done by the same person.
Yeah, and it just feels important to note, which will, link to another slide and topic, but, when you introduce helping someone go to the bathroom, that can really change the nature of your relationship. You might be entering into a space you have very explicitly never shared. And it can bring up all sorts of issues, or not issues, but sensitivities and feelings and values around modesty, around who sees our bodies and how, in terms of from a gender perspective, who is supposed to be with who and what circumstances. And,
Mhm.
those shifts, depending on the role we're in, can feel really small. Like, of course, I'm just here, like, I'm here to be of service to you, mom or dad. Like, let me help you with this. But actually, it rubs on something deep
Mhm.
for them around how the world is organized.
Mhm.
Yeah.
Yeah.
Listen to the next slide, BJ.
Yeah.
Really well.
Yeah. So exactly this changes relationships, illness, disability, needing care, giving care, can really change or enhance how we've fundamentally related to one another.
Mhm.
Know that when folks are dealing with these things in their bodies, like, their roles in the world are changing. Our abilities to work, to tend to our garden, to go to the grocery store, to pick up kids from school, and in such the folks around us helping to care for us, then the responsibilities change there, which then means the way that we're relating to one another changes. And because so much can happen and change quickly, we sometimes don't pause to take stock of, oh, we haven't gotten to just sit on the couch and read the newspaper together, or, oh, I don't feel like your wife anymore. It's a really painful thing to speak to. And yet speaking to it means we can then kind of take some time to think of, like, what is the 10 minutes a day where you can just be spouses? What is the activity in the day where you get to be a daughter again, or a son?
Mhm.
Yeah.
Oh,
Yeah. No,
well,
go
I was just to say, as you're talking, it makes me think a lot of just, the sheer amount of mourning that comes with serious illness, right? The future is never guaranteed, but there is often this loss of the future we had envisioned, right? This loss of function, this loss of the relationship dynamic as it was, right? And like you're saying, it impacts how we relate. It can have impacts on intimacy, on sex in some cases, depending on the nature of the relationship. And it's not to say that it's this terrible, full of despair, hopeless state, right? We can replace, old hopes with new hopes, and old dynamics with new dynamics, and old sources of beauty with new sources of beauty. But undoubtedly, with change comes just a profound amount of loss.
Mhm.
Yeah, and it's in the, like, acknowledging of it, the speaking to it,
Grieving it.
I think allows us to move to the next thing that promotes some capacity to feel like, oh, this is beautiful. This is a new frontier of intimacy. This is a new opportunity to be connected in deeper and different ways. But it's hard to get there if, we've got just this ache that we haven't been able to acknowledge or be seen in.
Yeah, and that just sort of, this has come up in other talks we've done here together. One way or another is just how dynamic all of this is. I mean, you can try to sort of be fixed in I am X or I am Y, and sometimes we hold each other to these roles when life is asking us to shift and change and move. It's a dynamic deal that we're in. So letting it change, rolling with these, seeing if you can get to this sort of curious, this exploratory kind of mindset can be very beautiful. But to get there, like you guys are saying, oftentimes taking means pausing, grieving the role that's in the rear view mirror, even as you're welcoming a new one, talking it out, being explicit. All of that can be really, really key. But this is also where where I think people start seeing how resilient they are, how much change they can actually metabolize. And relationships may land in places that people had never imagined. That happens too, in a positive sense, in an amazing sense. So much to say on here, but I will just say, it kind of touches on this slide and the last one, which is just to remember our fetish for independence. And I use that word on purpose. It's just, it doesn't really exist. So even if you're losing your independence, well, we've never been independent. We always need each other. It's just a matter of degree. And so here's a sort of where this can become very obvious, if painful. And the sooner I think we realize that sort of the truth of interdependence, that you may become, there's moments in life where you need to take a little bit more than you can give, and there's moments where you can give a little more than you take. That is normal. That is natural. That's not being a burden per se. Okay, guys, should I move us along? Yeah, okay. Well, this is a slide that this was a not someone, I can't remember who it was, one of it in prior webinars brought this to our attention, which is such an important thing. Kids often find themselves in caregiver roles. I had some that was part of my childhood to some degree. Again, I never thought of it as, we didn't talk about it as caregiving, but it's a huge education for me. It was a real eye-opener for me in a lot of ways about how we need each other, how we can care for each other. But never mind the particulars of my own experience. But the thing to note here is sometimes kids have to kind of put their childhood a little bit on hold to step into what can feel like very adult roles. And that's asking a lot of a kid, but it's also teaching them a ton. And it's just a nod to some sensitivities to finding ways for that kid to also be a kid, even when we're asking them to do pretty mature things. Yeah. What do you guys think? Anything coming up for you guys?
I guess I'm also thinking like part of the unfair ask of these kids is that, you know, death is a natural part of life and of human life, and but it's treated as so unnatural in modern society and in modern times. We often, like as a society, really, you know, turn a blind eye and shun death. And so I think of children of the past who probably had this happen far more often because people died a lot younger in the past. But it was so much more normalized and embraced sort of in societal culture than it is for these kids now who are experiencing this thing that feels like so wrong and so foreign, and it is a lot to put on them.
It just makes me think, you know, and this kind of goes back to the initial slide around uniqueness, but it's really hard to talk about caregiving not just in generalities that maybe sort of centers whiteness and white experiences. And you know, kids in caregiver roles exist differently in different cultural contexts. If you live in an intergenerational home, it might exist differently than if you've lived in a house where, or a family or a cultural structure where you really think that only X people are supposed to have X roles and it's my job to do this and their job to do that. And it's not appropriate to do something until you're an adult, right? Like there's just so many different value systems, cultural systems that are at play here with who gets put into what roles.
Mm-hmm.
So I'm just feeling like sensitive to sort of speaking to that.
Yeah.
And on the concrete, I mean, I feel like we can't get past this slide without giving just a very concrete shout out to child life services, and that there are, if you find yourself in a situation where kids are so exposed to this, there are experts who can talk you through, you know, like, how do I talk to kids about this? How do I help them integrate it and understand it in a developmentally appropriate way? And there's support.
Yeah, thank you, Dani. So child life services, guys, in case that is an actual field. It's a discipline. Oftentimes it's social workers and other psychotherapy trained folks, right? But not necessarily. Child life services is really worth asking about. It's a little appreciated field. It can do really beautiful things with families. And to your point, Dani, you know, talking with a 6-year-old is importantly different than talking with a 10-year-old. They're just in different places in their development, different capacities, different language, etc.
Well, I feel like we could like easily end up getting into a talk about just kids in general, but the one point that feels important to me to say is like when kids are around the scene of caregiving and illness, like it's important for more people in their community to know that that's going on. And sometimes that's tricky because we feel private about it and we're not ready to share. And if there's a way to feel comfortable making sure their counselor knows at school or their teacher knows that there are other eyes and ears watching,
Yeah.
when kids are away from home, to see how they're integrating. Is their play changing? Are they not paying attention? Are they,
Exhausted.
attached to their teachers? So, one way to build out support for kids in any role of caregiving, but also in any relationship to illness, is making sure that other people know what's going on so they can be looking out for them.
Yeah. I think the beauty of that too is I think as kids are sort of working on this balance of like, the world is a safe place. The world is this petrifying place. Right. And I think that when someone in your home is seriously ill, it can feel so much more weighted as the world is this scary, terrible, out of control place. And the more people who can be these safe spaces outside of that bubble for your kid, the more we can balance it out with this belief that we want them to have, that the world is also a really safe place. So
Yeah. And as you guys are talking, it's right. It's sort of another, it kind of points to why we have conversations like we're doing today, and why we're trying to do this in a more public fashion, all of us. It's because these are not things to be ashamed of. These are normal things. These are happening behind closed doors of homes all the time. And the more we can share that and talk about it and normalize it, the better in so many ways. Okay. Here we go. Dig in. I just want to jump in here. We kind of touched on this, and guys, I wonder if you want to say more, but again, all thoughts and feelings welcome. Thoughts and feelings just kind of come, and they can be kind of, I have many embarrassing thoughts a day, and we all do. And it's certainly true in caregiving. There are moments where you might actually feel like you want to like run away or strangle this person, or whatever it is, you want to howl at the moon. Unsavory thoughts are a big piece of daily life, and especially so within the frustrations that happen around the caregiving role, bumping up against an inadequate healthcare system. Oh my Lord. So just to say, this is just to be, again, this is not all but love and sweetness and kindness and hugs and no, there's a lot of hard thoughts that come with this, and that's totally normal. I've had talked to so many families who one way or another are embarrassed to confess that they were happy that their loved one finally died, that it was time or whatever else, and are celebrating that passing on some level. And that feels terrible. How can I be happy my mom died? Whatever it is. These are normal. It's totally normal, and it's welcome. So guys, anything you want to add to that? The unsavory thoughts you want to share?
no, I mean, I think there's like the unsavory thoughts that I think just come up for all of us, it's like part of the process. But I think also, I don't know, I think it was Bridget was talking earlier, like sometimes, what if we don't actually even like our loved one, right? What if we resent them, right? Or what if in the depth of their own pain and illness, they're treating us horribly? And so I do think that sometimes these relationships are messy, and as hard as it is to, see someone you love suffer, I think there's actually a unique pain that comes with having very conflicted feelings with the person that you're taking care of. So
yeah, and that was the kind of like on a different rant, but conflicted was the feeling that kind of kept coming up into my mind. We can feel like the last thing I want in the world is for my person to die, and I really feel like I'm going to feel really relieved when they die, right? And those are hard things to hold, especially around something so big as someone's death. But I can't tell you the number of sort of bedside conversations as someone's dying, where just sort of whispering like, it's normal to want this to be over and to not want it to ever end. And we feel that in like much more microscopic ways all the time, of like, I love this person and I hate them right now. I don't want to be anywhere else, and I want to be anywhere else. And so, just building some muscle around like conflicting things existing at the same time.
Amen. That comes up so much in illness. It just sort of forces us to mature in a way, to have a bigger cup to hold it all. That's one of its charms. Okay. Well, this
Big
one,
one.
yeah. I mean, this is huge. We've been one way or another, we've been talking about, we've been communicating
That's
about.
all we're talking about. And a
That's
lot of
all we're talking about. Just to name it. And so a lot of our, like on that last slide, we're talking about sort of some inner dialogues, but communicating these thoughts, whether with your person that you're caring for or with the healthcare team or your own shrink or wherever, is just to encourage all of us to actually find a way to communicate, whether it's through our words or our artwork, or express these things that are going on in us. Otherwise, some of these unsavory thoughts or conflicted thoughts, they grow horns and fangs, and they hang out in the dark of our inner world without some light, without some air around them. And you can feel so alone in this work, when in fact this is the oldest job in the world, and this is old ancient stuff, and you are not alone, etc. But until you communicate, it's very easy to feel alone. And also it's very difficult. Some of this stuff we're talking about here, even as you watch us fumble for words, there's really not a language, only gets us so far with some of the things that come up in this role. So anyway, those are some thoughts from my brain. What about you guys? Anything to add?
Who remembers Fred Rogers? Everybody knows Fred Rogers, right?
Mr. Rogers?
Mr. Rogers. Yeah, he taught us everything in life, right? But no, one of my favorite quotes from Mr. Rogers is, he said, if it's mentionable, it's manageable, right? If it's mentionable, it's manageable. And I love it because it speaks to just like, there is a relief that comes when we, use our words, our communication to invite our deepest fear or our biggest sadness or whatever it is into the room with us, right? It helps us tolerate it. It helps us process it. And I love your point about how it doesn't have to be that you say it to your loved one. It might be, but it could be any number of people. When you go mountain climbing, you have a belay, right? There's somebody there for you, and you just have to act like, who is my belay right now? Like who do I need to lean on right now?
Yeah, and it doesn't even have to be a human. I talk to my dog all the time, or whatever. It's just get it up, get it out.
My journal, yeah.
Yeah, journal, yeah.
I'm feeling humbled by like the bigness of all of these topics, because I think the thing that's going on in my mind is that so often the weight of caregiving is exhausting, right? It's a lot to hold. And then there's this whole world of communication that has to happen around the illness, with physicians, with medical centers, with the other folks that you're managing care with. And it's just like normal to miss things, right? In communication, to misunderstand, to not understand, to misinterpret. And when you're doing so much just to survive everyday life, what are the systems we can put in place to make the technical communication, the medical communication a little bit easier? Do you ask the doc to make sure you can voice record a session? Do you let your phone translate it? Do you bring another person with you to the visit to have another set of ears? Do you make it somebody else's job to send the text updates to the 5 other people that are really curious? So there's the communication importance of, speaking to our emotion and speaking to our process. And then there's the real tangible, how do we manage all of the communications that go around? And are there systems that we can put in place to make it easier? And can we be soft with ourselves when we miss things, when we forget, understand?
Right. So important, Bridge. Thanks for bringing us to the tactical. This, like a lot of our sessions at Mettle Health with people, are very often just translations. We're just translating words across language, medicalese to sort of normalese. Websites like Caring Bridge and others, where you can kind of have sort of singular modes of communication, so all well-wishers have some place to check in, and you don't have to have the same conversation over and over again. Another tactic is, if you're lucky for there to be a team of people around, a crew, multiple caregivers, multiple people participating, then sometimes assigning someone to do the sort of communication can be very helpful. So yeah, lots to this one. Bridge, thanks so much for bringing us back to the practical.
Lots to this one, but it's kind of making me hate this slide. Like I sort of hate this slide because the communication, like there's so much, like how do we come up with the questions that we're going to ask the oncologist? Like there's so much that can land under a communication that, let's burn this one.
Okay.
Just kidding. Let's turn it into 20 slides next time.
Right on. Well, speaking of which, I'm looking at the clock. We'll keep moving.
Yeah, let's do it.
Spare your mood as well as give us more time. Hold on. Well, yeah. I can jump in. Sorry, guys. I didn't mean to. But I mean, this is sort of also implied a little bit around communication too, but very often, especially when bumping up against systems, healthcare systems, social services, insurance, all the sort of structural bits around living with illness, et cetera, and caregiving for somebody. And as we know, we are critics of all those structures. There's a lot that could be so much better. So that's just a name that's implied in a lot of our comments. But here we are. This is the world we have right now. And that requires sometimes, like the healthcare system, the defaults in the healthcare system are often not what people want. For example, more ICU, intubation, all sorts of, if you're not speaking up for yourself or you don't have an advocate speaking up for you, you may often find yourself on these sort of what have been called conveyor belts, taking you places you don't want to go. So it means asking questions, clarifying, and making sure you're heard so you don't get treated as generic patient X, but as Mr. and Mrs. So-and-so with likes and dislikes and wishes, etc. So one way or another, we should all be advocating for ourselves. You can't really hand yourself over to this healthcare system anymore. Even if you're lucky to have a wonderful, caring doctor, they don't have the time. So you can't presuppose that they're just going to take perfect care of you. Marcus Welby doesn't really exist anymore. It's not possible to be a Marcus Welby in our healthcare system. So this means sometimes asking hard questions. Doctors may not answer that question. And sometimes as the caregiver, you may say, hey, doc, you didn't answer my question, or making a next appointment. Sometimes to get to tactics, like Bridget was saying, is, before a medical appointment, going in with your person, taking time to think through the 2 or 3 questions you need to get answered that day to prioritize things. So anyway, that can kind of get us started. Guys, any other notes?
I just feel like it's important to acknowledge that there's a real power dynamic here. And it can be really intimidating to stop a physician to say, I don't understand, right? And it can bring all sorts of stuff in us. Like when somebody's talking to us and assuming we understand, it can bring up all sorts of pride unconsciously, but there's all sorts of reactions. It says I shouldn't stop them. Like their time is precious. We do all of this sort of pedestaling of physicians and healthcare teams. I shouldn't stop them. I shouldn't interrupt them. And it's really courageous to do so. And so important to say, I don't understand what you just said. Can you say it again? Could you say it a different way? But I just want to acknowledge that while we're suggesting that you do that, it's hard. It's really hard. We are programmed to think that doctors know all the things and we're just supposed to get what they say. And often it's being spoken in a language that does not translate to us.
That's right. And
I would just add on, I think of course we do of course have to be an advocate, and I'm by all accounts just a very, very gentle people pleaser. So I hear what Bridget's saying is it's hard sometimes, but I will tell you, when my middle kid was in the ICU for months, I legitimately think that there were people in that hospital that were scared of me, because I knew enough about the medical system to see how many things were falling through, and I turned into this sort of unrecognizable, fierce beast in the setting. And so it is really hard to interface with this medical system. I don't want to downplay that at all. And I think I'll also say that the counterpart to being an advocate is that at the same time, we have to let go of this idea that there's, a crystal ball that's going to enable us to make all of the perfect decisions for our loved ones. Right. I was I was driving in the car with my 6-year-old just yesterday, and I took a certain turn. I went one route to where we were going, and we ended up at this red light that took, an eternity. And my poor kid, I was just sitting here like in this rabbit hole talking to her and being like, oh, I should have gone the other way, right? We wouldn't be late if I had gone the other way. DTD. And she actually stopped me and she was like, mommy, it is what it is. Bless her soul, right? But we have to let go of this idea of sort of right and wrong and replace it instead with sort of faith in the fact that we're doing our best and we are guided by a compass of caring in the choices that we make. And we advocate for our best guests.
It's just so good, right on. And you're also, especially in the setting of complex, serious, or chronic illness, by definition, these are things that are not going to get better in the long run. And so it can be very hard to gauge as a caregiver, what does success look like? Mom or dad or loved one is declining no matter what you do. Yeah. So it can be really tricky to know when you're doing enough, what decisions, missed opportunities are of consequence, which are not. So just to name, it can be really hard to gauge success or adequacy even. Here back to kind of communication and speaking these truths out loud so you can get some sense. And a lot of the questions you may have are just not answerable. Nobody knows, even that posturing doctor. So here again, this slide's the tip of an iceberg, but just to name that hard feeling of, even if your loved one is getting worse by some definition, that may not reflect poor care. That may just be the way things are going to go, no matter what you do.
Yeah. And self-compassion, right? A lot of times I think we feel like if I knew the right thing, of course I'd be advocating for it, but we're sort of walking around in the gray.
Mm-hmm. Oh yeah. Okay. Oh, that was the last slide. Ooh. Okay. All right, great. I'm gonna pop out of us, and now, dearly beloved audience, questions, comments, any stories to share?
Yeah, we had a question come in. We'll read this here. This person said, I'm finding myself pulling back from family and friends. I think it's a result of my desire to ease the suffering as my disease goes to the next level. Do you have any suggestions on dealing with it or addressing the suffering of others? I'm fully aware that all those offering to help or provide care will be present when needed, but it really is a head game.
Yeah, that's a goodie. Guys, I keep jumping in.
That's okay.
Is this, I'm looking in the chat too. Okay. Well,
I think it's hard. Are you gonna go? I'll jump in because it's so hard. And I think especially for those of us who are caregivers by nature, and then we end up in the ill role, and then we're trying to take care of everybody. It's not a thoughtful comment. We're trying to take care of everybody around us, and it is incredibly painful. And I think one thing I would say is it's gonna hurt. It's gonna hurt your loved ones, no matter how close or far it is from it, it's gonna hurt them. And I know you want so badly to protect them, but I just don't think that can be taken away, even if you distance them.
Yeah. And just because something's hard doesn't mean it isn't essential. And sometimes I think receiving care may be underneath this question too. I think it's a really difficult thing to do. We're talking about caregiving. Receiving this stuff can be so hard for so many reasons, including this idea that you don't want to be a burden, that you may be creating suffering in their lives, or maybe somehow feel like the source of suffering in their lives. I guess one thing to just encourage is this is life. This is love. This is again, we need each other. And maybe part of the answer here is taking on this idea of learning to receive care. Also, that it's also beautiful to care about the person caring for you. And I would encourage you to speak to that. This is really caregiving, care receiving. It's an exchange. And when it goes well, everyone's giving and receiving. So part of the answer here too may be, speaking to that piece of your mind and checking in on your loved ones. That can be a gorgeous thing. This is reciprocal. So.
And we're fixers by nature, right? We like to fix things. And so there's a powerlessness that comes with this caregiver role where you're sort of witnessing this terrible, possibly thing happening and you can't fix it, right? And there's a discomfort to that. But I will find, like, at least I found that having something that you feel like you're offering or doing actually is a really nice antidote, even if it's not changing the course of the train. Like just knowing that you gave somebody an experience, a moment of joy, you know, a cooked meal, just any little thing, it often helps the caregiver more than it helps the patient sometimes, because it helps be an antidote to that painful feeling of powerlessness when you watch someone you love suffer.
I think in our efforts to protect one another, we often assume incorrectly around what other people need. And I think in the spirit of actual interdependence and connection, I come back to, like, what we can know and what we have control over is like what we need and how we feel and what works for us, and we can offer that to others and invite them to offer it back to us, right? So maybe actually what you need right now is to pull back, or maybe it's not, maybe you need to fall into. I think that's like the most not authentic, because I think what you're doing is authentic too, but maybe it's the truest thing. And then that allows the other person to say, actually, I this is painful, but I gotta go home right now, or I can't be here, or I want to be closer, right? But inviting one another to be as honest as possible with what's true for us, I think, is one way through it.
Communication, that slide.
Your favorite.
My favorite.
But I will say, I mean, this is, again, it's a hard question to answer thoroughly, because it also depends who you're talking about. Like in some cases, I have done this where I think I'm protecting people by not asking them anything of them, or only to find they feel left out. And if you're trying to protect someone from the messiness of illness, or the messiness, or from suffering and the hard stuff, well, on some level you're preventing life. This is life. This is the deal. This is not the detour. This is it. So sharing it as ever is always so much the trick, and daring to be vulnerable can be the most amazing gift to those around you. And again, as I say that, you may fillet yourself. Here I am, be vulnerable, and people may not respond. So this is complicated stuff. But this is where I think a through line of honesty is such a good one. Not comfort or meaning, but honesty. Because it may be, the honest answer from someone may be, I can't be there. I just can't, for whatever reason. That may be real. And so if you attach your what's the word? Well, if the hook here is honesty or realness, that'll pull you through just about any situation. If you're trying to keep the through line happiness or ease, that seems less possible and less rich.
And BJ, I think one of the hardest parts often is actually identifying in ourselves, like, what is the honesty, right? Am I afraid that I'm a burden, right? Or is it actually just too painful for me to watch my loved one suffer? Or, it could be any number of things could be behind pulling back, and really taking the time and space with ourselves to figure out, like, what is at the core here? Probably step number one.
It's a beautiful question. Thank you. It's a rich one. There's so much there.
Rebecca's made a few comments about sort of sandwich caregiving and, what it is to take care of a kid or a child while your parent is dying.
Yeah. Was there also a question?
We've got another question that came in. This person just said, any advice for finding a balance between staying on top of healthcare details, issues, advocating, and then also letting things ride so you don't get twisted up over it?
Ooh, that's a big one. When to allow and just let things to be, and when to kind of push and force, when to fight, when to let go, however we want to language this. It's both. And one of the skills that one develops over time in this caregiving role is sort of the judgment of when to exercise which route. So yeah.
I've also noticed working with patients, even if the course is the same, there's a huge value when they find a provider that they trust. There's just a very big value that comes from not wondering or second guessing, do they have my best interest at heart? Have they taken the time to think through this? Finding somebody that you trust. And so if you do have that person anywhere in your team, use them. I feel like half of my palliative care clinic is really people coming in and running by things for me. And I like helped them do the sifting. This is something we should advocate for. I think they're doing standard of care. Like, let's let this one go. Because it is hard to make an infinite amount of micro decisions in an area that maybe isn't your expertise, and knowing when to make them or when not to. So find the person that you trust to help sift through that.
And it can be like an opportunity to look into in your system, like, who is the team? Are there social workers? Are there chaplains? Are there counselors? Who else is around that can help to accompany you, that can hear, that can advocate, that is within the system? That can be a helpful tool.
And then grace, right? You're going to over advocate something totally pointless. It's going to happen. And then you're going to under advocate something that maybe was big, like, but just having grace with ourselves, right? We are doing our best, feeling through it.
Yeah, and this, I think you implied, this is a great use of palliative care. So if you happen to be in a system where there is a palliative care program, or if any of you guys are reaching out to us at Mettle Health, this is a safe place to think out loud and to bounce ideas around. Can be so helpful.
And if you have a more specific question, because we can follow up afterwards, but I guess part of what I'm curious about is like letting what ride, like a medical detail, a medical decision, your house being clean. What is the thing that you're letting ride, and how are you weighing that?
Yeah. Okay, wait, guys, look at the time. Is there any, Sonia, were there any hands up or anything else to squeeze in under the wire?
Yeah, 1 second. We've got one last one. Dani, Bridget, are you okay to do a couple more minutes here? I want to be respectful of your time. Okay.
We just might have like a tiny interloper.
That's okay. Okay, this person said, as a professional caregiver, I sometimes struggle with the balance of the honesty while also keeping my emotions in check. Emotions in check. There are times where I cry just a little bit while being with people, and then I feel guilty in a way, like I am supposed to be the one who's quote unquote keeping it together. And yet it also is honest, and I feel it provides a space for connection too. What advice do you have in maintaining this balance? How do you feel about showing certain emotions while you're in a professional caregiver role? That's a good one.
I have thoughts on this one.
Take it away, Dani.
No, I mean, I think, well, I will first say that there has to be a place for us as caregivers to share emotions. There has to be a place where we can cry, like hands down. And I think the question you're asking is like, when should that place be with the person that I'm caring for, and how much? And there's no one answer to it, because there are times that I cry with a patient that I'm caring for, and it is so connecting and they feel so cared for. And then there are other times, and I think I got to hold it together, because if I cry right now, it's going to take something from them. They're going to have to let go and take care of me. And so I do think that we have to find a place for our emotions, but that question about when it's with the person I'm caring for, we have to really dig deep and take our best guess of, does this serve? Like, if I cry right now, why am I doing it? Am I doing it for me, or am I doing it for them? Because the answer is not the same between any two situations or any two moments. But I love the interloper. Hello.
Yeah, and I echo, I'm with Dani. There's not a pat answer to this question. I will just say that in general, sometimes there's no choice. Tears just come. I mean, and a lot of our comments imply there's all sorts of choice in so much of this stuff. And oftentimes there just isn't. So back to the through line of being real. And oftentimes I would say, especially for professional caregivers, I think shedding a tear can be one of the most healing thing for your patient and family, that you were moved as a professional, you were moved by their situation, can be really, really powerful. And to your point, Dani, though, are you seeking it's different to pull the spotlight onto yourself and your own needs versus just to be real in the situation.
Being human.
I would watch for frequency too, right? Like if it's that you cry occasionally when you feel moved, like I think that's human, and people want other human beings in the room with them.
Period.
You're crying every time you see a patient. Maybe that's a moment to step back and think about what else you need and what else is going on for you, and what other supports are, for your own well-being. So I would think about frequency, because sometimes in those moments it's impossible to really pull back and be like, this is about me, and oh, this is about them, and then you lose that sort of like thread of humanness.
Right on.
Yeah.
I think that's a beautiful way to end.
Before we end, at the risk of being cheesy, we talked at the very start, full circle, about this idea of setting an intention. And I'm wondering if we could just take like one small moment for us all to think about and set an intention for ourselves today. And you can keep it to yourself, or you can throw it into the chat, but it's so easy. So let's just do it once.
Got it?
Got it.
All right, you beauties. Man, it's such a pleasure.
Wonderful.
Oh, thank you, everybody.
Yeah, and everyone, thanks for your thoughts, your comments, your questions. It is just beautiful to be with you guys. So thank you.
Yeah. Happy weekend to everyone. Thanks for being here.
Bye.
Bye, guys.